Hello, good afternoon, everybody. Thank you for joining us today. My name is Chandrika Gowda. I'm Associate Professor at Penn State Children's Hospital at Hershey, and I have the pleasure of moderating the webinar session today entitled Bone Marrow Failure Syndromes, Updates and Advances for the American Society of Pediatric Hematology Oncology webinar series. I have a few housekeeping items before we get started. Please note that all the participants have been muted for the presentation this afternoon. I would like to direct your attention to the question box on your screen. It's on the right-hand panel. Please use this to ask any questions during the presentations. And you can type in questions as you get it throughout the talk, and I will direct the questions to the speakers at the end of our presentation. You can also use this area to let me know about any audiovisual issues or technical difficulties that you are having during the presentations. I would now like to introduce our speakers. Our speakers for today are Dr. Elissa Firutani and Dr. Akiko Shimamura. Dr. Firutani is an instructor at Dana-Farber Boston Children's Hospital, and Dr. Akiko Shimamura is the director of the Bone Marrow Failure and MDS program at Dana-Farber Boston Children's Hospital.
Thank you very much to ASPHO for the opportunity to present today, and thank you to Dr. Gowda for moderating this session on bone marrow failure. Here are our learning objectives for today. At the end of the session, the goal is for all of you to be able to incorporate inherited bone marrow failure syndromes into the differential diagnosis of cytopenias, order and interpret appropriate diagnostic studies, describe the genetic basis and pathophysiology of these disorders, and also be able to discuss new therapeutic advances and investigational therapy with your patients. Here's the agenda for today. We'll start with a brief intro and then dive into the workup and management considerations before then spending some time on each of the individual diseases. And at the end of this portion of the talk, I'll hand it over to Akiko, who will then discuss somatic genomics in these rare diseases. I do want to let you know that we will be incorporating live polling into this webinar. And so as part of this, we will start with a question here, and I'd like to briefly review why each of you are spending some time taking time out of your busy day to learn about these disorders today. So if you could vote on your screen here, the poll should pop up on your computer. Please select one of the following in terms of why learn about these rare inherited bone marrow failure syndromes. Is it A, these account for a significant subset of marrow failure, B, early diagnosis informs clinical care, C, studying them advances our understanding of hematopoiesis and cancer predisposition, or D, all of the above? Excellent. So as I hope to convince you today, it is important to note that while each of these are rare, collectively these disorders account for a significant subset of marrow failure, and I hope to convince you that the early diagnosis informs clinical care and share with you some of the latest scientific understandings in terms of the pathophysiology of these disorders as well. So let's get started with an introduction to bone marrow failure. These syndromes are a group of genetic disorders characterized by hyperproductive cytopenias, and here you have a normal cellular bone marrow on the left and a bone marrow replaced by fat on the right, as can be seen in some of these disorders. As you can see, there are very few hematopoietic elements in between all of the fat cells in the stroma. Bone marrow failure can be thought of in two different categories, so inherited, which is also known as genetic, and then acquired here on the right. For the purposes of this seminar, I will be focusing on the inherited group of syndromes here on the left. And I'll proceed with a basic overview of the workup of these disorders, and then we'll dive into the specific diseases. So in terms of the general workup, if you are seeing a patient in clinic with cytopenias and you're wondering about inherited bone marrow failure syndrome, key points include review of prior CVCs, especially looking for macrocytosis and reviewing the MCV over time, asking about frequent or unusual infections, such as the use of antibiotics for recurrent bacterial infections or difficult to treat bacterial infections, as well as questions regarding fungal infections, as well as a review of any potential congenital anomalies. Patients who have already been treated for malignancy should also be asked about excessive toxicity with chemotherapy or radiation. Taking a full family pedigree, especially with assistance from a genetic counselor, will yield useful information rather than generically asking if any hematologic problems run in the family. Updating the family history at future visits is also helpful, as frequently families will learn more either at Thanksgiving dinner or when they have had a chance to review with their extended family. We also recommend reviewing parental CBCs, as I've been surprised that sometimes patients may not know, or family members of patients may not know that their platelet count has been just at about 100,000. And in addition, asking specific questions to screen for suspected bone marrow failure may include asking about congenital anomalies, pulmonary fibrosis, liver disease, solid tumors, as well as leukemia and MDS in family members as well. Also, assessing whether there is consanguinity in the family can also be helpful for elucidating the potential for recessive conditions. Critically, however, I do want to point out that a negative family history does not rule out inherited bone marrow failure conditions. Some of these reasons can include incomplete information, as some families don't share medical information readily, or you may have estranged family members, recessive inheritance pattern, and thus neither side may be expected to have manifestations of disease, variable penetrance with asymptomatic individuals or others with mild disease that hasn't been picked up yet, latent manifestations that can take many decades to develop disease, or disease anticipation where subsequent generations have more severe disease manifestations, gonadal mosaicism, so multiple individuals in the same generation are affected but parents are unaffected, or de novo mutations such as that individual is being evaluated may actually be the first patient to have the mutation in the family. In terms of the actual physical exam portion, I always also include growth charts as being part of this section, as that can be helpful in terms of looking at growth over time, as well as assessing whether or not the patient may have failure to thrive. The physical exams should also include examination of the skin, including evaluation for any hyper or hypopigmented patches, specifically looking at the oral mucosa, focusing on evaluation of any leukoplakia, assessing the dentition and also gum health, as well as hair fragility, and assessment of the nails on both the hands and the feet, which of course can be more difficult if patients are wearing things like nail polish, so asking those questions carefully as well. And in terms of evaluating for any radial ray abnormalities, we recommend assessing for the symmetry of radial pulses, assessing the thenar eminences, as well as whether or not they're able to supinate or pronate. As some of these radial ray abnormalities, as we'll discuss further, can go along with several of these genetic conditions. The initial workup in terms of laboratory assessments include a CBC with differential and a reticulocyte count, as well as evaluation of a peripheral smear, assessment of immune function with immunoglobulins and lymphocyte subsets, functional studies such as chromosomal breakage and telomere length, which we'll go into more detail in subsequent slides, and also may include assessment of exocrine pancreatic dysfunction or ADA levels as indicated. An additional workup will, of course, depend on the specific clinical scenario. With regards to the bone marrow examination, in terms of looking for inherited bone marrow failure syndromes, this includes an aspirate for morphology, and the biopsy is also critical in terms of assessment of the cellularity. Additional tests listed here can be sent and also vary by institution. I do want to point out that there are some common cytogenetic and somatic molecular abnormalities which are associated with specific bone marrow failure syndromes, and these are listed here. If you find these can be a tip-off to the presence of these disorders, so it's critical to understand about some of these common cytogenetic abnormalities and their associations. Of course, the workup can also include germline genetic testing. This can be done off of skin fibroblasts, as it is less sensitive when sent from blood because of somatic mosaicism or somatic reversion. And I've also just included some additional consideration when you're assessing the results of the genetic testing to see whether or not it fits the clinical presentation, fits the inheritance pattern, and assessment of whether or not that variant is pathogenic. This can be a whole discussion in and of itself, so I won't get into all the details for the purposes of this presentation, but just to note that there can be a wide range of phenotypic spectrum with regards to the clinical presentation, and the asterisk for the inheritance pattern is just to note that, again, all the caveats as we had discussed earlier with regards to the family history in terms of why there can be a negative family history and yet the variant that your patient has may still well be pathogenic. Now, as you had all voted earlier, how does the diagnosis of inherited bone marrow failure syndromes change management? With accurate early diagnosis, patients can be appropriately screened for associated congenital anomalies, such as horseshoe kidneys or solitary kidneys, or maybe cardiac anomalies, and have screening put into place. Patients can also be monitored for the development of marrow failure with regular routine blood counts and have tailored treatment plans put into place. In general, patients should be considered for transplant when they develop severe or symptomatic cytopenias or are heading towards transfusion dependence. I'll mention here that many of these marrow failure syndromes are associated with predisposition to myeloid malignancies, such as MDS or AML, and you can see that the risk varies based on the disease, which of course then influences the specific monitoring with that particular disease. In addition, and here are some of the MDS and AML surveillance strategies. Again, this will vary based on disease, but can include assessment of serial CBCs as well as serial bone marrow examinations. In addition, some of the bone marrow failure syndromes have an increased predisposition to solid tumors, which continues to be a risk for patients that transplant does not ameliorate. And we'll talk about this a little bit further in some of the other specific diseases as well. With regards to how an accurate early diagnosis changes management for transplant, pre-transplant evaluations can be completed in a thoughtful way and does not have to be rushed at the time of, for example, MDS or AML. And it's critical that related donors be screened appropriately for the disease at hand, since, again, these can run in families. Conditioning regimens also need to be considered carefully and adapted to the specific disorder, as some of these disorders do have specific toxicities with either chemotherapy or radiation. And there has really been significant improvements in transplant conditioning regimens over the past few decades. And of course, genetic counseling is critical for the whole family. Now I'd like to move on to the second part of the talk, in which case we'll be getting into more details of each of the inherited bone marrow failure syndromes listed here. So for our next poll here, which bone marrow failure syndrome is associated with this particular diagnostic test? Great. So as most of you had voted here, we will be discussing Fanconi anemia. Let me just get onto this slide here. So Fanconi anemia is a DNA repair defect that leads to double-stranded breaks. The diagnostic test, as you had voted on, is increased chromosomal breakage in response to DEB and MMC, or diethoxybutane and mitomycin C. It can be useful to send diagnostic testing, which includes both of these agents. There are currently 23 genes implicated in FA, including BRCA1 and BRCA2. And the inheritance pattern is autosomal recessive with two exceptions, FANCB, which is X-linked, and FANCR, which is autosomal dominant. Useful acronyms in terms of thinking about the workup for Fanconi anemia are Bacterial H, as many of these patients are actually picked up on a screening CBC when they're having their thumb repair or other surgical repairs associated with their congenital anomalies. And here I just wanted to mention that Drs. Alter and Giri at the NIH also came up with the acronym PHENOS as a reminder to look for these particular features when assessing a patient with bacterial features to see whether or not they may have Fanconi anemia, as the bacterial patients will not have these particular PHENOS features. I do want to mention here, though, that this list is not 100% comprehensive, and that patients can also have none of these features and still have Fanconi anemia. With regards to the pathophysiology, the FA pathway, as I mentioned, is important in repairing interstrand crosslinks and double-stranded DNA repair. The most recently described FA proteins are included here in bold, and there are genetically undefined cases of FA, and we anticipate that the number of genes implicated in FA will continue to grow. With regards to management considerations, patients need to be monitored for both solid tumors as well as for myeloid malignancies. And current available medical therapies include androgen therapy such as danazol or oxymetholone, hematopoietic growth factors, and transfusion support. Transplant is also available for bone marrow failure, and there are special considerations when treating solid tumors given the exquisite sensitivity to both radiation and chemotherapy in this disease. Thus, early detection and surgical resection is a mainstay in the treatment of solid tumors. Patients should also be counseled to avoid tobacco, alcohol, and toxins, and to undergo surveillance for these solid tumors. So there are multiple medical therapies currently in trial under investigation. These include those associated with FAR funding, including metformin, altrombopag, and quercetin. And for full disclosure, I'm the PI on the metformin trial, which is based off of preclinical data from Dr. Marcus Gromke's group in Oregon, which had demonstrated improved blood counts and delayed tumor formation in Fanconi mice, as well as decreased chromosomal breakage and cell lines from patients with Fanconi anemia after they were treated with metformin. Other studies under investigation, of course, include quercetin, which is an antioxidant, and altrombopag, which is a TPO mimetic. Gene therapy is also in the early stages, mostly targeting Fanconi anemia gene A or FANC-A. Thus far, there have been lentiviral vectors in early stages with no conditioning regimens, again, because of the increased toxicity to chemotherapy that I had mentioned before. And a recent report from Spain demonstrated a repopulation advantage of the corrected CD34 cells and stabilized blood counts in patients who had received the infusion of the corrected gene product. Follow-up is still short, so we anticipate further long-term follow-up data from this trial. And as you all know, transplant approaches with T depletion and omission or dose de-escalation of TBI have really improved outcomes in transplant for FA. And on the horizon, we expect that alternative conditioning regimens for transplant using antibody-mediated approaches should be in trials soon. Now moving on to the next disorder, which clinical features are associated with this laboratory finding? I'll give you all a second to vote here. Great. Sort of move on and talk. We are talking about dyskeratosis congenita, which are also called the telomere biology disorders. And as you had accurately mentioned, there is a wide phenotypic spectrum, which includes pulmonary fibrosis, liver disease, immune dysregulation, and AVM, in addition, of course, to the bone marrow failure. These are disorders in telomeres, which are really critical for maintaining chromosome ends and are important in aging. And the diagnosis is made by very short telomeres, less than the first percentile, and at least 3 lymphocyte subsets by flow fish. And that was a chart that you were looking at earlier on that slide. Mutations for this disease occur in genes in the telomerase or the sheltering complexes, which act in concert to prevent premature shortening of the chromosomes, end-to-end fusions, translocations, or breaks. Then the telomerase complex is actually a ribonuclear protein complexes that catalyzes the addition of telomeric DNA repeats. And the sheltering complex is a multi-protein complex that protects telomeres. The most common mutations are in DKC1, which are X-linked, TERC, which is autosomal dominant, and TERT, which is both autosomal dominant and autosomal recessive forms. And other mutations occur in either the core protein complex or sheltering complex genes, but those are actually significantly more rare as compared to those main 3 genes which can be affected in this disorder. Similar to FA, this is a multi-system disease, and clinical features of DC include, but are not limited to, things like nail dystrophy, which is why it's critical to look at that in terms of a physical exam, leukoplakia, skin hypo or hyperpigmentation, as well as the findings that that you had all voted on earlier. Thank you very much for bringing these back up. I also just want to mention that early graying is a characteristic finding, so it's just also critical as you're performing the physical exam to also ask if patients are dyeing their hair, asking about enteropathy, of course, immune dysregulation, and CNS abnormalities. Patients are at risk of bone marrow failure, cancer, including AML, and also specifically carcinomas in this particular disease of the colon, esophagus, pancreas, skin, and bronchus. So disease anticipation occurs in autosomal dominant forms of DC, and as you can see here, telomere lengths shorten with subsequent generations, and thus patients may have a negative family history even if their ancestors carry the same mutation. And thus future generations with this mutation are also expected to present at an earlier age. Novel therapeutic approaches for DC include danazol as therapy, which has been associated with the outgrowth of cells with longer telomere length, treatment over time. And transplant for DC has actually been difficult because many patients with DC have baseline organ dysfunction and are also prone to increased toxicities from transplant conditioning regimens. Given that we would expect there to be a competitive advantage for donor stem cells, a radiation-free, alkylator-free approach using just alemtuzumab and fludarabine is now being studied as part of a multi-center study for bone marrow failure, and this is affiliated with the patient and family group Team Telomere. So expect to hear more about these types of transplant approaches in the future. Moving on from DC, Shwachman-Diamond syndrome is a ribosomopathy resulting from biallelic mutations in the SBDS. These are critical for promoting 40S and 60S ribosome joining. And this disorder is characterized by both exocrine pancreatic insufficiency as well as cytopenias. So importantly, there are some patients who can have a genetic diagnosis of SDS without cytopenias. And I want to mention that there are novel genes described recently with patients having an SDS-like phenotype, and these include DNA JC21, ESL1, both of which are autosomal recessive, and SRP54, which is an autosomal dominant condition. Diagnostic testing really relies on both genetic testing as well as a clinical diagnosis, as there can be patients who meet clinical diagnostic criteria for Shwachman-Diamond syndrome but are still genetically undefined. And one thing I want to mention here too is that when you're reviewing the peripheral smear or bone marrow aspirates of patients with Shwachman-Diamond syndrome, you can see these hypogranulated and also hypolobated neutrophils, which are demonstrated here. So that can be a tip-off to this disorder. There are variable clinical features associated with SDS, which include, of course, marrow failure with the characteristic neutrophils, and then cytogenetic abnormalities, specifically isochromosome 7q and deletion of 20q are really common in SDS. Along with the exocrine pancreatic insufficiency, patients can have low levels of fat-soluble vitamins, and with low vitamin K can have coagulopathies. Patients can have skeletal and dental anomalies, transaminitis, which actually typically resolves with age, immunologic abnormalities, cardiac abnormalities, endocrinopathies, and also developmental delay. Patients most typically develop neutropenia over other cytopenias, and treatment approaches can include Gcsf for neutropenia and transplant for either bone marrow failure or MDS. Unfortunately, this is also a disorder associated with cancer predisposition, and the outcomes of myeloid malignancies are currently dismal. And this is evidenced by a recent multi-center retrospective study characterizing MDS and AML and Shwachman-Diamond syndrome. These numbers for overall survival of both MDS and AML are worse than for patients with de novo MDS without genetic predisposition. And this is because of both increased toxicity to therapy as well as because of refractory disease. And as you can see here, the 3-year overall survival, 51% for MDS, 11% for AML are dismal. This is a retrospective study by the Shwachman-Diamond Registry and 18 collaborating institutions. that both Archbishop Marrow and I were involved in, and is an example of the kinds of advances that have been made possible by registries and rare diseases. And we're very grateful to our colleagues who have referred patients for the study and for the registry. I do want to note that the diagnosis of MDS and AML is also further complicated by the fact that oftentimes the diagnosis can be confusing because of the cytogenetic abnormalities that I mentioned in this patient cohort, so ISO7Q and deletion 20Q, for example, that are not necessarily associated with MDS or AML, or that those are not diagnostic for MDS or AML. And as I had mentioned, marrows can have dysmorphologies at baseline. So it's really critical to have somebody with experience in these disorders review the pathology of these marrows. And in this study, we actually had a central pathology review with both Mark Fleming and Tarek El-Ghattani, who are both experienced metapathologists with expertise in Shwachman-Diamond syndrome. So there was actually great concordance between the two central hematopathologists, but only 56% concordance with the local diagnosis, which just highlights the importance of studying this further and having these marrows reviewed by somebody who has seen many of these Shwachman-Diamond marrows. We still need to understand more about the role of surveillance in these disorders, and as part of this study, critical takeaways were that our current surveillance techniques are inadequate. We need to understand how to use molecular testing to help guide our management, and Akiko will touch on that in later slides as well. However, though numbers were small, patients who have been receiving surveillance with routine bone marrows had a trend towards better survival compared to those who did not receive surveillance. You can see that on the panel on the right. And notably, changes in CBC did not always occur prior to the diagnosis of MDS, and patients were not always macrocytic prior to the development of malignancy. And so efforts in the registry are currently ongoing to better understand the drivers of malignancy and also determine ways to risk stratify patients, as well as to develop novel therapies for this patient population. Potential future approaches for bone marrow failure treatment in FDS include gene therapy, given the frequency of several specific mutations, as well as other potential future therapies which are not yet in clinical trials, but include potentially small molecule inhibitors targeting TGF-beta hyperactivation, which is a theme in many of these marrow failure disorders. And recently there's been a publication on atalurin, which can suppress non-cis mutations in Shwachman-Diamond syndrome. Transplant approaches are currently being investigated and include an open trial of treosulfan-based conditioning regimen, treosulfan and fludarabine, which is currently open and enrolling. Now, continuing on our theme of ribosomopathies, there are now 24 genes implicated in diamond-blackfan anemia, of which most are ribosomal protein genes, but also now include GATA1 as the first non-ribosomal protein gene. Workup for DBA includes elevated erythrocyte ABA or the corresponding gene mutations. And diagnostic criteria include age at less than 1 year of presentation, and normocytic or macrocytic reticulocytopenic anemia with bone marrow findings of pure red cell aplasia. However, I do want to note, as I put here in gray, that adults can also be diagnosed with DBA, and the phenotypic spectrum has continued to expand. Additional supporting criteria for this disorder include elevated hemoglobin F percentage, which can be seen in marrow stress in many of these marrow failure syndromes, as well as positive family history and corresponding congenital anomalies. Clinical features can also include short stature, facial dysmorphism, radial ray abnormalities, cardiac malformations, and renal malformations, in addition to the hematologic findings I just mentioned. And patients are predisposed to different solid tumors from the other marrow failure syndromes. These actually include osteosarcoma, soft tissue sarcomas, and GI and colon cancer. Current available therapies include corticosteroids, transfusions with chelation therapy or transplant, and be on the lookout for new clinical care guidelines, which are expected to be published soon. Novel therapies and clinical trials in collaboration with the Diamond-Blackfan Anemia Registry, or DBAR, includes sotatercept, which is targeting the TGF-beta pathway via an activin ligand trap. And as you can see, this is a theme throughout several of the marrow failure syndromes. And TSP, or trifluoroperazine, which is actually a calmodulin inhibitor, which modulates the p53 pathway in DBA. And both of these clinical trials are now enrolling. Now for a case. We have a previously healthy 9-year-old boy who presents with MDS with monosomy 7 and 10% blasts. His past medical history includes normal development and normal growth and no previous hospitalizations. The last time he had a CBC was at age 5, and as you can see here, he had a white count of 5, hemoglobin of 11.8, platelets of 150, MCV of 94, neutrophil count of 1,700, lymphocyte count of 2,000, and a monocyte count of 50. His family history is negative. He has a healthy HLA-matched sibling who has a normal CBC. And on physical exam, he has some petechiae, several warts on his palms, no radial ray abnormalities, no facial dysmorphism, and an otherwise normal exam. With regards to his workup, the chromosomal breakage studies and telomere lengths were all normal. So given this clinical scenario, which gene do you think is most likely to be affected in this case? You can vote on your computer here. Excellent. So I think the important points here are that there can be multiple genes that can be affected with MDS with monosomy 7. And so those associated with monosomy 7 include GATA2, CMD9L, as well as SDS. In this case, this was a case for GATA2. And now for part 2 of this case, it turns out that on the diagnostic marrow, he had a somatic mutation panel that was sent, and that actually did include GATA2, and this returned negative for any mutations. So what is your next step in terms of workup and management? You can vote here. Excellent. So I think many of you are getting to the point here, which is that a somatic mutation panel sent off with the bone marrow is not going to necessarily be able to capture germline mutations. And so C is correct. D is also correct that the somatic mutation panel does not necessarily capture all of the mutations that can be associated with germline disease, and so both C and D are correct in this case. This really brings up a couple important points with this case, and that's why I picked this. One is that GATA2 and tronic mutations can really easily be missed, and some genes like GATA2 can harbor both germline and somatic mutations. One of the other genes that can do that is also CMD9 and CMD9L, and several of you have astutely noted that that can also present with monosomy 7. Here's a list of genes that can be responsible for somatic mutations in malignancy as well as in the cause of inherited disorders. And please note that this list is not entirely comprehensive as we continue to understand more about both somatic drivers of malignancy as well as identify novel genetic conditions. So I do expect this list to grow. Notably, variant allele frequency, or VAF, does not definitively distinguish germline versus somatic origin because of copy number variants, loss of heterozygosity, uniparental disomy, as well as differences in analytic pipelines. Notably, the title of the panel can also be misleading. So sequencing platforms are agnostic to the origin of a mutation, whether it's germline versus somatic. And so to determine whether a mutation is germline, you can test germline tissues, such as skin fibroblasts, and also test other family members. While any one panel can pick up both somatic and germline mutations, These panels are not equivalent in their coverage, and somatic mutations can occur in various hotspots that may be covered by the somatic mutation panel, which then may not cover the entire region of the gene, and that's why some of the intronic mutations for GATA2 are not picked up on the somatic mutation panel. Now moving on to more about GATA2. This is a transcription factor required for normal hematopoiesis, and haploinsufficiency can lead to disease. Mutations are inherited in an autosomal dominant fashion, and diagnosis is generally through diagnostic testing with a caveat that we just reviewed. GATA2 deficiency syndromes have actually many different flavors, such as Emberger syndrome, Mono-MAC syndrome, which includes recurrent infections, including mycobacterial infections, DMCL syndrome with decreased dendritic cells, B cells, and NK cells, and familial MDS AML, which is pretty self-explanatory. And any of the above can include other features of GATA2, such as pulmonary complications, lymphatic abnormalities, sensory neural hearing loss, or hypothyroidism, as well as a unifying marrow failure and myeloid neoplasms, which can occur in any of these syndromes. Notably, these bone marrows also have characteristic megakaryocyte lineage dysplasia, as well as increased fibrosis. A recent case report underscores the importance of identifying germline disorders prior to transplant to avoid transplanting back the same affected gene. And this is broadly applicable to all of the inherited bone marrow failure syndromes. Notably, and Aki will touch on this a little bit more too, GATA2 patients can also have mutations in a variety of MDS-associated genes, both in the bone marrow failure and immunodeficiency phenotypes, as well as in those who actually go on to develop MDS. And similar to the other previous disorders that we discussed, I anticipate more to come in the understanding of the somatic evolution of myeloid malignancies, which we hope will inform the surveillance and management of these patients. Now moving on to SAMD9 and SAMD9L. These are homologs which are involved in the suppression of cell proliferation, and activating mutations in these genes can cause disease. Typically, these are due to de novo mutations given the severity of the phenotype, although recently we've been understanding that there is a wider phenotypic spectrum than initially realized, and that mutations can still be inherited in an autosomal dominant fashion. In some cases in our clinic, parents have been diagnosed after their child was worked up for this condition, and no one knew that they had previously had a hematologic disorder. Clinical features of SAMD9 are summarized with a mnemonic MIRAGE, which stands for myelodysplasia, infections, restriction of growth. Many are born IUGR and premature, and patients can have difficulty gaining weight despite adequate nutrition. Patients can present with adrenal insufficiency, genital abnormalities, and enteropathy. Classically, SAMD9L mutations are associated with ataxia pancytopenia, and imaging findings can also include a hypoplastic cerebellum. However, in reality, there's considerable overlap between these two disorders, which is why oftentimes you'll see them reported as SAMD9/SAMD9L disorders. And patients can also have none of these associated features and just have cytopenias or myeloid malignancy, and monosomy 7 is quite common. So interestingly, the selective pressures to alleviate the hematopoietic repression by the activating germline mutations leads to additional somatic loss-of-function mutations in SAMD9 or SAMD9L, as well as escape mechanisms through monosomy 7 or del7q to essentially delete the affected activating mutation since the gene is located on 7q. And escape mechanisms can also occur through uniparental trisomy. So these somatic mutations can make it difficult to detect the germline mutations in the blood and bone marrow, so it's critical to think about this with if you see somatic mutations in these genes, as well as if you see monosomy 7 or del7q. There have also been reports of spontaneous remission because of somatic reversions, and on the left you see dysplasia, which resolves with spontaneous remission on the right-hand side because of these somatic mutations. I want to end with mentioning two relatively recently described marrow failure syndromes, MECOM and ERCC6L2. So mutations in MECOM, which encode EZI1, lead to radial ulnar synostosis with amegakaryocytic thrombocytopenia. The clinical picture is now expanded from the three initial cases described that now include bone marrow failure, clinodactyly, cardiac and renal malformations, as well as B-cell deficiency and hearing loss. And we now know that patients can just present with the radial ulnar synostosis with no hematologic involvement, and others can present with severe bone marrow failure without skeletal anomalies. And radial ulnar synostosis and the B-cell deficiency we're now understanding are associated with mutations in a specific part of the zinc finger domain of EZI1. The other recently described syndrome is ERCC6L2. This leads to bone marrow failure through a DNA repair defect with genomic instability and mitochondrial dysfunction. However, unlike FA, these patients have normal chromosomal breakage analysis. And I think we'll continue to learn more about these disorders as there is significant phenotypic variability. But for now, we do know that there is an association with developmental delay, microcephaly, as well as craniofacial anomalies, and also retinal abnormalities have been described in this syndrome as well. And as we understand more about the pathophysiology of these disorders, I anticipate hopefully there'll be some more targeted therapies in the future. So with that, I'll turn it over to Akiko for a discussion on somatic genomics and these disorders.
Hello, good afternoon, everyone. So I just wanted to take, in the last few minutes, a little discussion about a rapidly evolving field with the availability of somatic mutation testing, particularly in the field of malignancies, to explore how this might be informative for the inherited marrow failure syndromes, and what we do know and what we don't know, which is also very important. So basically the questions we'll explore very briefly are: what are the mechanisms driving clonal evolution to myeloid malignancies in inherited bone marrow failure syndromes, and can somatic mutational analyses inform clinical prognosis? This was one of the early studies that was done by Jane Cherpek and Tim Graubert and colleagues looking at myeloid malignancies in patients with germline, RUNX1, and GATA2 mutations. And as you can see on the right in the blue bars, patients with MDS or AML had, by targeted sequencing, somatic mutations in known sort of genes that have been involved in myeloid malignancies. However, if you look on the left, these are patients who are asymptomatic with germline RUNX1 mutations. You can see that 6 of the 9 asymptomatic patients without myeloid malignancies also have clonal hematopoiesis with mutations in genes that are known to be involved in myeloid malignancies, including, for example, DNMT3A mutation that's designated there. So this was a clue that we can have clonal hematopoiesis going on even at very young ages, relatively young ages, in known myeloid malignancy genes in these inherited marrow failure syndromes. And this is a theme that was known for a long time, actually. Particularly, I chose this as an example. These are just a few isolated examples. There's a lot more in the literature. But in this case, severe congenital neutropenia, which we did not have time to talk about here, where this is a figure from a paper by Dan Link, but this was shown in the New England Journal and in blood by prior groups such as Ivo Tau and Carl Velsey's group, that there is a propensity for these patients to develop acquired somatic mutations in the gene encoding the Gcsf receptor, the CSF3R gene. And these tend to be truncating mutations, removing the C terminus, resulting in autoactivation. And when they compared actually healthy patients versus patients with cyclic neutropenia, which is not associated with a high risk of myeloid malignancy, versus severe congenital neutropenia, which is associated with a high risk of myeloid malignancy, the increased propensity to develop these CSF3R mutations is largely limited to SCN. In contrast, Shwachman-Diamond syndrome, which as Alyssa mentioned is also associated with a high risk of myeloid malignancies, is not associated with somatic CSF3R mutations. In contrast, Dan, in the same paper, and we collaborated with him on this, showed that patients with Shwachman-Diamond syndrome, while they lack CSF3R mutations, have a high incidence of p53 mutations, which in contrast are not seen in patients with severe congenital neutropenia, cyclic neutropenia, or healthy controls. And the variant allele frequency was typically low, and there was some association with age, although again, note that these are all very young patients in the pediatric age range. But there was some association with age. So what does this mean? Well, this came out around the same time that a seminal paper from Coleman Lindsley and Ben Ebert in collaboration with the CIBMTR showed that in a tour de force sequencing of 1,514 patients with MDS who went on to bone marrow transplant, that about 3 to 4% of these patients had unrecognized Shwachman-Diamond syndrome. They found 2 SPDS mutations in these patients. And you can see that these patients with 2 SPDS mutations had a poor prognosis. Survival was poor. And all of these patients who developed MDS, who had Shwachman-Diamond syndrome, had tended to have p53 mutations, right? So the percentage of patients with p53 mutations was 100% in those with 2 SPDS mutations. So how then do we use this information? And I think the complexity of these data was highlighted by another very impressive study in the New England Journal of Medicine from Neil Young's group in collaboration with Seishi Ogawa's group in Japan and Jarek Massachusetts' group in Cleveland, where they looked at 439 patients with aplastic anemia, seemingly idiopathic aplastic anemia, and found that a large percentage of these patients eventually developed somatic mutations in genes that are known to be mutated in myeloid malignancies, including DNMT3A, ASXL1. They also saw some mutations in genes that were preferentially mutated actually in marrow failure, such as PIG-A and perhaps B-core. And so what they did was they looked, I don't have time to go through the data, but what they showed was there was no clear correlation between somatic mutations and clinical outcomes, although there was an association with certain mutations with perhaps an increased risk of poor outcomes, but it wasn't absolute. So it's difficult to know from these data how to use the identification of a somatic mutation in a given patient. So although you can give estimates of risk, it's hard to know what to recommend for a specific individual patient based on these data. So I don't have a lot of time, so I'm not going to go through the pathophysiology. I want to leave time for questions, but there's a lot of work going on now in sort of drivers of somatic mutations and myeloid malignancy, and this is an evolving field that remains, much work remains to be done. So basically we're left with the following questions. We do not know the prognostic significance or clinical actionability of somatic mutations arising outside the context of myeloid malignancies. These somatic mutations cannot yet be used in isolation to drive clinical management. And right now we don't know whether somatic mutations are deterministic in and of themselves. So we need more data to understand how to integrate the somatic mutation analyses into clinical surveillance strategies. But I think that this is a very exciting opportunity, and hopefully in the future, as more data comes out, we'll know how to integrate this into our clinical management.
Great. So in summary, I hope you found this overview helpful, and I hope that you are able to maintain a high index of suspicion for inherited bone marrow failure syndrome, as timely diagnosis does impact management. New genes continue to be discovered, and I think that this will really continue to improve our understanding of the molecular underpinnings of these disorders, as well as hematopoiesis more generally. Stay tuned for additional medical therapies which are moving into clinical trials, as well as novel transplant approaches. And we do need better new treatment approaches for MDS and leukemia, as well as for the solid tumor risk in some of these conditions. And as Akiko mentioned, I think much more to come in terms of our understanding of somatic genomics and how to integrate them into clinical care. So with that, thank you all very much for participating in the polls and also for your attention and for logging on today. And with that, we'll be happy to take any questions.
Excellent. Thank you to both of our speakers for this excellent talk. I have a few questions here. I'm going to read out the first question. One of our attendees asked, are Gcsf or erythropoietin associated with accelerated progression to MDS or myeloid leukemias in BMF syndromes?
So that's a good question. In terms of the most amount of data has really been in severe congenital neutropenia, and it's not well understood whether or not the patients who have more severe disease and thus those that need Gcsf are also the same ones that may go on to develop myeloid malignancy, even if that had been in the absence of Gcsf. So work is still being done to try to better elucidate whether or not it's that the patients with more severe disease are the ones that need Gcsf, or whether or not the Gcsf is associated with more outgrowth of the clones that are specifically primed to develop into myeloid malignancy. With regards to ASPHO, I don't know that there is specific data on that.
Yeah, so I would say, this is Akiko, I would chime in, and I agree with everything Alyssa said, but there are no data to rigorously show that Gcsf or erythropoietin drive or cause malignancy in these patients. So, there's always the possibility that if there's a malignant clone lurking in there somewhere, that maybe you could stimulate its growth, but there's no data to demonstrate that these cause malignancy.
Okay, thank you. The next question I have is, what is generally the accepted frequent surveillance marrows in a non-transfusion dependent patient? Is it every 3 months reasonable, or more or less?
And so this actually depends on the disease at hand. So for example, for Fanconi anemia, when the risk of myeloid malignancies is significantly higher, for example, than in DBA or in dyskeratosis congenita, the risk-benefit to performing marrows, and especially for our pediatric patients who need sedation, the benefit is higher in that disorder. So typically for Fanconi anemia, in the absence of any cytogenetic abnormalities, typically most people will do that about once a year. That's what's been recommended in the Fanconi field. However, that is different for the other disorders, again, really relative to the risk-benefit ratio. And that's something that we're better trying to understand. One, what is the risk of myeloid malignancy? How does that change with time? How does that change with prior treatment? And the other thing that I expect to change is the way that we perform surveillance. So currently we're able to do things like cytogenetics, FISH. We do have more ability to do somatic genomic analysis for the bone marrow samples, but the question is, again, what to do with those findings. So I hope that we will have better surveillance strategies in the future.
This is Akiko. I would just add that, as Alyssa said, one of the factors in sort of your consideration of how frequently to do surveillance or do any surveillance at all is the risk of malignancy. And it's also the risk of outcomes if you do not catch them before they develop malignancy. So there are some disorders, as Alyssa showed recently, a paper came out showing that malignancies, myeloid malignancies in patients with Shwachman-Diamond syndrome have a poor prognosis. Whereas early transplant, if you catch them before they actually develop full-blown leukemia, their outcomes are much better. So there is a compelling rationale there to perform regular surveillance. And currently, the consensus recommendation is once a year for marrows and blood counts, usually about anywhere from 2 to 4 times per year, depending on the patient and the risk. But then there are other disorders where if there's no advantage to trying to catch something early, or if it's not possible to catch something early, then the benefit may not be worth the risk of the procedure. So it's really tailored to the individual disorder.
Thank you. I have another question along the same lines, and both of you partially answered this already. Are there any other bone marrow failure disorders other than Shwachman-Diamond syndrome where surveillance bone marrows have been shown to be associated with improved clinical outcomes?
So this is Akiko. I have to say that in the field of Fanconi anemia, it's not been published, but I was at a workshop and the major Fanconi centers were showing their data, and there was a lot of leukemia cases in the early days, and then all of a sudden the incidence of leukemia went down. And that happens to coincide with the institution of annual surveillance. So that per se doesn't prove causality, but I think that it was pretty compelling that at several different centers across the world, there was this trend. And I have to say that we here have personal experience of doing a surveillance marrow in someone for whom we did not suspect clinically, sort of smoldering clonal evolution, and we found something that required a transplant. So the kickbacks that I get and the comments that I get from people as well, what do you mean that someone has leukemia and we don't know it? It's like, no, that's not what I mean. What I mean is there's somebody who is heading towards leukemia, but they don't have it yet. And that's where the marrow can be helpful.
Nice, thank you. I have one last question here. If there are any more questions, please, type it in. Last question, has anyone used danazol post bone marrow transplant in dyskeratosis congenita with a view to protecting liver, lungs, etc.?
So I don't know of any published data that people have used that post bone marrow transplant. I think most of the uses of danazol and with the published data from the NIH group has been using it to prevent bone marrow failure or in treatment of patients who have cytopenias, but that has all been pre-transplant.
It's an intriguing question, though, given the data, at least in the hematopoietic system, that there was an improvement in the telomere length. It's unclear whether a given cell elongates its telomeres or whether there's a selection towards those cell populations that have longer telomeres upon treatment with danazol, and whether that's a globally applicable process to other organ systems, I think is still an area of active investigation. So I think that remains to be seen.
And I think this question also gets at something underlying too, which is that we do need ways to protect other organs, because again, this is all of these are sort of multi-system disorders, not just affecting the hematopoietic system. So trying to find new ways to for chemoprotection during transplant, or trying to prevent some of these other complications and organ problems post-transplant, I think this question gets at that, the need for that.
Nice, thank you. I have one last question, and again, in the lines of bone marrow surveillance, if you're doing it annually and the patient's not transfusion dependent, what's the longest kind of latency period you have seen before you see dysplastic changes or changes to MDS? I have a patient who has gotten annual marrows like 4 or 5 years now. Nothing has changed, just hypocellular marrow, and they're not transfusion dependent. So how long does this usually take?
Well, that's a great question, and I guess what you might be getting at is, who do we not need to do marrows on, right? Like,
right.
And we
Right.
don't know. Right, exactly, and I wish I knew the answer to that. What I can tell you is we anecdotally get calls from patients with Shwachman-Diamond syndrome who've developed leukemia, and they will share that they were not getting surveillance marrows because their cytopenias were mild, and therefore they concluded that their disease was mild and they didn't need surveillance. I would say that even patients with mild cytopenia who seem to be clinically well are still at risk for developing leukemia. If they were not transfusion dependent, there was no antecedent symptomatic cytopenia preceding the leukemia for a subset of patients. What we hope through research that's currently ongoing is that, particularly with somatic mutation analyses, not only will we be able to risk stratify those patients at high risk for malignancy for whom surveillance is useful, but perhaps also identify a low-risk population, right? Maybe if you lack any somatic mutations, maybe you don't need to have surveillance marrows so frequently, or maybe any surveillance marrows at all, at least for some time. So we don't know the answer to that yet. And so right now, what we do is we enter into a dialogue with the family, because, you know, there are some families that really don't want to have annual marrows, and we just are upfront with them about potential risks of leukemia, but also the lack of clarity about, you know, who really needs these annual marrows, and try to partner with them to reach the best decision for that family.
And I do hope, too, that soon we'll have better ways of actually doing testing of peripheral blood as well, to try to look at what's happening in the marrow in terms of somatic genomics as well. So I think more to come from that perspective as well.
Great. Thank you very much. I would love to thank both Dr. Fiorentani and Dr. Shimamura for that excellent talk and answering our questions. I don't see any more questions from our participants. I would like to thank everybody who logged in to hear the webinar as well. At the last, I want to put in a plug-in for the ASPHO annual meeting that's coming up in May. It's from 6th to 9th of May this year in Fort Worth, Texas. Deadline for registration is March 31st, so please go in and register. I would like to thank you again, both of our speakers and ASPHO staff, for helping us put this together. Thanks, everyone.
Thank you all very much.
Thank you.